Good evening, dear colleagues, and welcome to this edition of the live webinar organized by the European Association of Cardiovascular Imaging and dedicated to the highlights of EuroEcho-Imaging, which was held last month in Lisbon. I am Bogdan Popescu. I work in Bucharest, Romania, and I'm the current EACVI president. And I have the pleasure to be here tonight with my colleague and friend, Professor Ervan Donal, who works in Rennes in France, and who is the EACVI vice president, as he is the chair of the ECHO section, and he is also the scientific chairperson of this attractive congress that we are going to discuss tonight. This is meant to be an interactive webinar, so please ask your questions, and we will do our best to give you the answers as much as possible during this hour of the webinar, and the questions that will not be answered due to time reasons during this time, we will answer nevertheless during the following days, and so you will get the answers. I think I would like to start first by giving you some key facts about the Congress, and then Ervan will present a selection of the best abstracts that were presented under three big categories, and after each of these three big presentations, we will stop and we will discuss it and we will take your questions. So I would like first of all to thank to the Scientific Program Committee for their hard work. They have put together an amazing program that was very well appreciated, particularly to the chairs, Ervan, who is here with me, and Thor Edvardsen, the president-elect of our association, and also the other colleagues, particularly to Julien Magne, who was the scientific program director, the program advisors, Elena Galli, Bernard Kozins, the education chair, the education committee chair, Denisa Muraru, Nuno Cardim, as well as the section chairs and all the other members of the scientific program committee. They are to be commended for this. As you know, EuroEcho-Imaging is the biggest cardiovascular imaging congress in the world, as it attracts a very broad audience, and we had actually participants from over 90 countries, and the program was with a good mix of both education sessions. We had more than 115 scientific sessions, as well as research that were featured both as oral abstract sessions and as poster sessions. And also we have benefit to have close to 400 key opinion leaders as representing the faculty for this Congress, coming from 46 countries. This was a very successful Congress, and we are happy to report that it broke the record of the audience, getting close to 4,000 total participants, as you can see here, much higher than the previous record, which was in Vienna 3 years ago. Here you can see the top 10 registration figures by country for the last 4 editions, and we have a good mix from different areas of Europe, as you can see, and we have in top 5 Italy, UK, Portugal as the host country, Netherlands and Romania, as well as the other countries that you see listed here. And of note, all of them have participated with larger numbers of colleagues attending the Congress. Again, as I said, and this will be the highlight of tonight, we had an important component of this Congress represented by original research, both in form of original abstract but also presentation of clinical cases. And you can see on this slide that we had the highest number of abstracts accepted for presentation in the Congress, and we also had the highest number of clinical cases submitted and presented. So this was a good chance for the young colleagues to be present and to show their work in front of a great audience. Here are again the top 10 countries, this time in terms of accepted abstracts and clinical cases. And you can see here that not only did we have many countries from Europe, but we also had in top 5 Japan with 47 abstracts accepted and presented, and also Egypt had 28 abstracts. We are happy to report very briefly data from this post-Congress survey we just received, and we are analyzing this information But you can see here that with a high response rate and more than a quarter of those asked have responded to the questions, 94% overall of these respondents described the Congress as being either great, 63%, or okay as a general impression, 30%. So this is quite a good feedback, and we will go in the following period into the specifics of it in order to try and improve it further for the next edition. Before giving the floor to Ervan, I would like to also thank the EACVI Board for their hard work and commitment that made it all possible to have such successful meetings and projects within our association. So now it's my pleasure to invite Ervan to start with the first topic of his selection. Ervan, please.
Thank you, Bogdan. Hello, dear friends. It's a real pleasure to be here today with you to discuss about some part of the science that have been proposed to us for during the past Congress that we had in Lisbon. So it was very hard for me to do the selection, and you will see at the end that I was helped by a lot of colleagues that were able to present the highlights at the Congress on Saturday. So first of all, I will present a few abstracts dedicated to valvular heart diseases. You will see how important are the improvement in imaging techniques for the assessment of the heart valve diseases. And first of all, I want to share with you this beautiful German study that has been performed in 60 patients sent to surgery for a severe aortic valve stenosis. This patient had only a severe aortic valve stenosis, and they were assessed before the surgery and follow up to 10 years. All these patients got a biopsy of the left ventricle to check for the presence of fibrosis or not. And all these patients got also a cardiac MRI to measure the fibrosis of the left ventricle. And the authors were able to distinguish three populations: one without any kind of fibrosis, one with a severe fibrosis of the left ventricle, and the second group with a mild presence of fibrosis within the left ventricle myocardium. And as you can see on that slide, it is quite astonishing to see that there is a relationship between the symptomatic status of the patients and the presence of fibrosis. And the beauty of that study is that it's even true before the surgery, but also after the surgery at 9 months and even at 10 years. And you see that more fibrosis you are, more risk you have to be symptomatic or to be dead at 10 years after the aortic valve replacement. And you see on that Kaplan-Meier curve that there is a clear distinction between patients with a severe fibrosis before the surgery and the patient without any kind of fibrosis before surgery. You see that the group of patients without fibrosis has a much better prognosis than the patient with a severe fibrosis. So this is quite important to consider this presence of fibrosis in patients that might be sent for surgery for a severe isolated aortic valve stenosis. And you see on the multivariate analysis that both the fibrosis assessed by the biopsies and the fibrosis assessed by the lead gadolinium enhancement, so the cardiac MR, were both parameters associated with the risk of death and with the risk of events. Let's discuss a second abstract that has been submitted by a Korean group, and this is a study performed in cardiac magnetic resonance imaging, again about patients with a severe isolated aortic valve stenosis. And the authors were able to use the cardiac magnetic resonance imaging in this group of patients with aortic valve stenosis to assess the presence of fibrosis using the non-contrast T1 value, using the extracellular volume, and also, and that's the beauty of that abstract, is that they were able to check for the myocardial strain in the longitudinal direction, the radial direction, and the circumferential direction. So they use the CMR to get the fibrosis and to get the LV function. So they did that in 60 patients with a severe isolated aortic valve stenosis, and they were able to follow these patients. All these patients got a CMR, all these patients got an echo pre-operation and after the aortic valve replacement. As you can see, this is quite easy. You observe that there is a quite good relationship or good correlation between the longitudinal strain and the non-contrast T1 value. This is really true for the longitudinal strain. It is less obvious for the circumferential and the radial strain. When you look at the extracellular volume, you again observe the linear relationship between the longitudinal strain and the extracellular volume, and this is also true for the circumferential strain, but not for the radial strain. Now, when you look at the change in the LV mass from before to after the aortic valve replacement, you are able to observe that there is a clear relationship between the pre-operative longitudinal strain and the change in LV mass from before to after aortic valve replacement. That means that strain parameters can be measured easily by cardiac magnetic resonance imaging. These strain parameters are related to the presence of fibrosis. These strain parameters are related to the reverse remodeling, and longitudinal strain independently predict the LV mass index regression. Let's discuss now about mitral regurgitation, primary mitral regurgitation. And this abstract that have been submitted by a Swedish group use the algorithm that has been published by our American friends about the assessment of primary mitral regurg and to distinguish between mild, moderate, and severe mitral regurgitation. Our American colleagues consider that we have to use 7 quantitative parameters to make sure that the mitral regurg is severe or not. The authors use this algorithm, so use a complete echo assessment of their patients, but they also use a cardiac MR to measure the regurgitant volume, the regurgitant fraction, and to assess the presence or not of a severe mitral regurgitation. As you can see, there is a relationship, there is a correlation between all the echo parameters that we use to assess the presence of severe MR or not, and the assessment of the MR severity by cardiac magnetic resonance imaging. But this correlation is perfect for none of these single parameters. It's why when we use echo to assess a mitral regurg, we have to consider the assessment of several parameters, and none can be used for itself. When you look at the algorithm that has been proposed by our American colleague, it is quite interesting to see that if you have at least 4 criteria in favor for severe mitral regurg, when you compare the result that you get with echo and with cardiac MR, the agreement is quite perfect. That means that as soon as you are able to quantify correctly the mitral regurg by echo, it's not necessary probably to do a cardiac MR. But when you can't get all the parameters that you need to get to quantify the mitral regurg by echo, you can do wrong things. And you can observe that when you don't have all the parameters that should be quantified usually, the discrepancy between the assessment of the degree of severity of the mitral regurg by echo and by CMR is not good enough. Then, it is probably important to keep in mind that the algorithm that has been proposed by our American colleagues is very good to rule in severe mitral regurg, but probably not to rule out severe mitral regurg. And when we are in doubt, when we are not able to precisely quantify our mitral regurg by echo, perhaps we should consider the use of magnetic resonance imaging to make sure that we are right.
Great. Thank you very much, Ervan. I think that was very interesting. And indeed, valve heart disease is a very relevant topic for daily clinical practice. Just to discuss a little bit, and we already have 2 questions to take. I think this is a hot issue now, myocardial function through different means, looking not only at function but also at structure, fibrosis combined with deformation. And the first abstract that you presented reminded me of another study that was presented in Barcelona at the ESC last summer from an UK multi-center study, again using CMR, where they did something similar. They looked at fibrosis. They operated patients with severe MR with replacement of the valve, either surgical or transcatheter, and then followed up those patients and tried to see predictors of outcome. And again, fibrosis, and particularly the presence of scar, came out as a strong independent predictor of outcome. And interesting enough, that was true regardless of the etiology of scar, which means that was true even in patients without coronary artery disease, and also irrespective of the type of intervention, either surgical or transcatheter. However, they didn't have in their study combination of advanced echo by measuring global strain, which we know from other pathologies that correlates with fibrosis, for example in hypertrophic cardiomyopathy. So probably looking at these parameters combined, both fibrosis by CMR and GLS by echo, could possibly provide more data and could fine-tune the timing of surgery for such patients. And in this line, we have a question here from Norway that the colleague is asking us if we should routinely do MRI in assessing a patient with asymptomatic severe AS in order to decide whether to operate. What do you think about that?
Thank you, our Norwegian colleague, and thank you, Bogdan. This is a very nice question, actually, because you see, I'm mainly an echo guy, and in that part of the highlight session, I presented CMR data mainly. Why? Because I think that we have new parameters that are coming using cardiac MR, and these parameters looks very promising, but we have to be careful. And we are an association, a multimodality association, but this multimodality association doesn't mean that we should do all the imaging techniques to every single patient.
Right.
The importance in heart valve disease is to keep in mind that the key tool first is the echo assessment. And if we use correctly the echo assessment of these heart valve diseases, we should solve most of the issues. So we shouldn't do, I think at least, a cardiac MR in every single patient with a heart valve disease. Right. But echo people should know that using another technique, which is the cardiac MR, we can do sometimes better, and we can correct our mind when we are in doubt. So sometimes it's difficult to make sure that we have to send a patient to surgery or to the cath lab. So if we are in doubt, we can discuss with colleagues, and also we can use another modality to confirm or to change our mind about the severity of a disease. So cardiac MR is strong. We believe in cardiac MR, but it's not the first choice. The first choice is echo. And for the young community, it's quite important, I think, to keep in mind that first, we should be strong in echo before learning cardiac MR, because it's the key tool that we have to use for every single patient.
I agree. I think these are very important comments that you highlight. And another question which is kind of related to this is coming from Russia, is asking about global longitudinal strain and outcome. And I think we also have data accumulating about the role of GLS in prediction of outcome in patients with severe AS. from different publications and even from one coming from the EACVI. Would you like to develop on that?
Yes, I think this is, again, very important. Nowadays, it's possible to get GLS by cardiac MR, but we have a lot of data available using GLS in the aortic valve stenosis, in the mitral regurgitation, using echo. And even as you said, we have a meta-analysis that has been performed by the association last year, demonstrating that using GLS by echo, we can predict the risk of death in asymptomatic aortic valve stenosis patients. So GLS, even in asymptomatic patient with a severe aortic valve stenosis, is a very strong and independent prognostic marker that we should keep in mind.
Okay, I was just looking here what we got. Similar questions, if strain by echo can guide the timing of surgery for asymptomatic AS. I think you just replied.
Actually, I replied, but as you know, if you look very carefully at the heart valve disease guidelines, GLS is nowhere, which means, again, for the young community, that we have to work more. We have to build large cohorts to make sure that we confirm this result that we have in small studies. You saw the abstract that I showed you. These abstracts were done in 60 patients. It's not enough to get to the guidelines. So in the future, we really have to do larger studies to make sure that our imaging techniques are useful to best take care of our patients.
I agree. I think GLS is gaining momentum. It's probably the most robust of the deformation parameter we can measure by echo. But still, we need larger studies. We need to really figure out the intervendor variability and establish the cutoff values to be used in practice for every clinical setting, in this case, severe AS. But it holds a lot of promise, and combine it with the other parameters would allow us to take the best decisions for our patients. So I think that for the interest of time, we should move to the second section now, please.
Thank you, Bogdan. So, dear colleague, now we will discuss a bit about abstracts that have been sent to the Congress about the assessment of ventricular function. And I will start with the speckle tracking approach. So the speckle tracking approach using echo is GLS, as we discussed, but we have new things, new tools that are very promising. First of all, I want to highlight the fact that nowadays we can get an assessment of LV function, regional and global LV function, combining the information of the LV pressure, estimated LV pressure, and the longitudinal strain. So you can get, as you see, the pressure strain loops, and these pressure strain loops can be obtained non-invasively using an equation that uses the brachial artery cuff pressure measurements. So nowadays we can get pressure strain loops only non-invasively. It has been used in few papers, and one of them has been presented during the last EuroEcho meeting in Lisbon. In that paper, we were able to check very precisely to the echo before any implantation of a CRT device in 100 patients, and these patients were followed. The goal was to know if using these pressure strain loops, we can best predict the success rate of CRT. As you can see, it has been demonstrated in that study that considering the myocardial work, the positive myocardial work, with a cutoff value of 1057 millimeters of mercury per percent, and the wasted work, which is the work that is loose because it happened after the aortic valve closure, we can predict the success rate of CRT. And we were able to demonstrate in a multivariable analysis that the addition of this myocardial work analysis can improve the power of imaging techniques to predict the success rate of CRT. So this pressure strain loops are very promising. Let me discuss again about this new approach of using strain in echo, considering this experimental study. This is an important study because when we check for the LV function nowadays, using ejection fraction, using GLS, we are not assessing contractility. We are assessing something that is close to contractility, but something that is very afterload dependent. Using the pressure strain loops, we can assess the impact of afterload on the LV deformation. And you see in a normal patient, the pressure strain loops in a normal patient without an increase in afterload, and after the increase in afterload, there is some degree of changes, but not that much. When you look at a patient with a left bundle branch block, you see that you have a septal flash here. If you increase the afterload, you have a severe change, a dramatic change in LV strain, and this dramatic change in LV strain within the septum is related to the presence of a negative work. So please take care of these new tools. These are very promising to best assess the function, the regional function of our patient with left bundle branch block, with ischemic heart disease, and so on. Another approach that can be used considering the speckle tracking analysis is the assessment of the dispersion of the peaks. This is a nice study performed in Oslo, and as you can see, the authors were able to compare athletes and genotype positive hypertrophic cardiomyopathy with a mild phenotype. It is sometimes complicated to know what is a normal heart in an athlete and what is a hypertrophic cardiomyopathy with a mild phenotype. In that study, the authors look at the 3D dataset and look at the speckle tracking longitudinal strain. As you can see, they were able to demonstrate that the LV volumes are larger in athletes than in hypertrophic cardiomyopathy patients. When they looked at the global longitudinal strain, the values were similar in both groups. But when they look at the dispersion of the peak strains in the longitudinal axis, they were able to demonstrate a huge difference between the two populations, with much more dispersion in hypertrophic patients than in athletes. With a cutoff value of 44 milliseconds, they were able to clearly distinguish who are the normal patient and who are the patient with an hypertrophic cardiomyopathy. I will spend 5 seconds describing this because we will discuss that afterwards. You see, you have here the longitudinal deformation, and you see that all the peaks are coming all together at the end of systole. There is quite no dispersion. This is a normal heart. Here you have the same GLS, but you see the heterogeneity in the peaks and in the timing of these peaks. Some peaks are before the aortic valve closure, some peaks are after the aortic valve closure. There is an important dispersion in peaks. This is an hypertrophic cardiomyopathy. This dispersion sync can be used also maybe to predict the risk of ventricular arrhythmias. In that nice study that has been performed in Italy, you see that authors looked at the dispersion to predict the risk of ventricular arrhythmias. But not only in patients that are suitable for an ICD, I mean not only in patients with an LV ejection fraction below 30%, but also in patients at risk with an LV ejection fraction greater than 30%. So they were able to demonstrate that if the dispersion is lower than 56 milliseconds, you see that the risk of arrhythmias, ventricular arrhythmias, is quite absent. In the whole cohort, but also in patients with a preserved LV ejection fraction. In opposite, if you have a severe dispersion in longitudinal peaks, you see that the risk of events it's much higher. So this is quite interesting to see that in this population of 100 patients, in patients with a decrease in LV ejection fraction, the fact that you don't have any dispersion is associated with no risk of arrhythmia, and that was also observed in patients with a preserved LV ejection fraction. But in this patient with a preserved ejection fraction, if you have some degree of mechanical dispersion, with this cutoff value of 56, you see that the risk of ventricular arrhythmia is quite high. So this tool might be very useful in the future to best select patients for an ICD. Let's discuss now a bit about 3D echo. There are a lot of new things in 3D echo. A lot of posters have been presented. And I want to highlight two abstracts about the assessment of the right ventricle. First, this nice Italian study performed in Luigi Badano and Denisa Moraru lab. And in that beautiful abstract, you see that 300 unselected patients were assessed by echo, and they were followed for up to 4 years. And in that study, the authors were able to demonstrate that using a cutoff value of 35%, the 3D assessment of right ventricular ejection fraction is a strong prognostic marker for all-cause deaths in this group of unselected patients. So it seems very important to know that nowadays we can measure LV ejection fraction by 3D echo, and it seems to be better than when we use TAPC or the other tools that we have in conventional echocardiography. And let me now discuss this beautiful study that has been done by a Budapest team. And in that study, authors looked at the LV function before and after a surgery for treating a severe mitral regurgitation. So it was a study in patients with a mitral regurg, but dedicated to the assessment of the LV. And the beauty of that study is that authors were able to assess separately the longitudinal component of the LV ejection fraction and the radial component of the LV ejection fraction. And in that study, they were able to show that before surgery, the LV ejection fraction is mainly driven by the longitudinal component of LV deformation. After surgery, there is a decrease in the longitudinal component of LV deformation, and that is compensated by the radial component to provide the same LV ejection fraction before and after surgery. Before, the longitudinal function is key. After, the radial component is key. And to finish this part of my presentation, I want to highlight a new approach to use imaging techniques for the cath lab. This is not an echo study, this is a CT study, a beautiful CT study. Because nowadays, when we have to implant a prosthesis, an occluder to occlude the left atrial appendage, we select the size and the type of prosthesis before and during the procedure using the CT data and using the echo data. The idea here is to use a perfect CT scanner and a 3D printing of the left atrial appendage to best select the device that we will be able to implant, and then to improve the quality of the occlusion of the left atrial appendage. So then for that, the authors use a perfect angio CT of the left atrial appendage. They use some kind of image treatment, an automatic segmentation of the left atrial appendage. And then they did a 3D printing of the left atrial appendage to test the prosthesis, and each prosthesis according to the size of the prosthesis to improve the quality of the implantation when they will be in the cath lab. So this is a new approach to use echo that seems to be very promising.
Thank you very much, Erwan. Another very important piece of data, again, LV function, which is the daily thing we are doing in any imaging lab. So I can summarize, I think, again, mechanical dispersion comes on top of GLS, so to say. So it's both important, the amplitude of deformation, but also the timing of deformation. And when you combine these two sort of data, you get more reliable information in terms of diagnosis. For example, as you showed, you can differentiate HOCM from athlete's heart. In terms of prognosis, because patients with higher dispersion tend to have more events, arrhythmic events. And perhaps even in future, even in terms of treatment, if we will be again able to introduce this in some decision algorithm, for example, to prevent sudden death by ICD and so on. So I think that's a very important point. And it tends to come more often in different settings that we see hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, and other diseases. One point about right ventricular function, I think that was an elegant study, because we often tend to just focus on a parameter, forgetting what it actually interrogates, what it actually correlates with. For example, TAPSE is good because it's easy to use, it's useful, but of course it only tells you about the longitudinal motion. So whenever there are settings in which the geometry and the function of the heart is altered because of other interventions that were performed, like here surgery, we need to keep in mind that our parameters should reflect the specific pathophysiology of that patient. And so understanding the type of patient we are scanning and we are analyzing is very important in order to use these parameters in a meaningful way. And finally, 3D printing. We did not develop on this today, but I think this is also used more and more because whenever we have interventions nowadays, 3D printing is particularly helpful. And you just show a case in left atrial appendage, but we know this is also the case in complex congenital heart disease, where it helps very much the surgeon to understand the complex anatomy and to really plan well the operation. So I think it's important to come back perhaps a little bit on this very interesting cardiac work parameter that seems to be something that really has the potential to add information to what we currently have. So again, maybe you would like to stress about the load dependence of various LV function parameters and how using such a thing may potentially help us to get a new data.
So
load dependence of...
Yes, the load dependence is key. I think it's important to keep in mind that, yes, we use LV ejection fraction. It's mandatory for many aspects. We decide treatment according to LV ejection fraction, but LV ejection fraction is highly load dependent. We both believe that GLS could be or should be added to LV ejection fraction to best describe the LV systolic function of our patients. But still, GLS is load dependent. The fact that nowadays we can get these pressure strain loops might help to best understand the impact of load on what we are measuring. So it might be very useful for the future. But maybe I can highlight something that we didn't discuss yet, is the fact that if we want to democratize all these tools, we have first to make sure that the quality of the image that we get is okay. So the image quality is key if we want to have a robust assessment of GLS, if we want to measure the pressure strain loops, we still need very good image quality in echo, in CMR, and so on. So this is very important for the imaging community to keep in mind that we have fancy tools
Yes.
that improve the way we think about our patients, but first of all, we have to acquire very good data to make sure that what we are doing is robust.
Exactly. I think that's an important point. You need to have very good image quality to be able to do this assessment. Let's just take a couple of questions before moving to the last section of your presentation. There is a question here. In patients who have an EF of the left ventricle which is borderline normal, is strain more reliable than 3D, especially in oncology patients who needs LV assessment during their cancer therapy?
Thank you for that question. It's an important question. So 3D is better than 2D if we can get good data, good images. But 3D is still, according to the question, measuring LV ejection fraction. So if you use 3D to measure LV ejection fraction, this is still LV ejection fraction. So it is probably better to use GLS because GLS is more sensitive than LV ejection fraction, whatever the technique you use to measure this LV ejection fraction. So 3D is better than 3D to measure LV ejection fraction, and we need to measure LV ejection fraction. But to get a more sensitive tool to small changes in LV systolic function, GLS seems to be better.
Yes, I agree, and I think we have data now also coming from large studies, from the SUCCOR study, looking at this and looking at the potential of GLS to replace ejection fraction as a measure of LV function, able to detect early LV dysfunction due to chemotherapy. And maybe one more question before moving. It's a question about a patient with a dysynchronous left ventricle, whether in such a patient strain is appropriate or what should we use to assess LV function when there is really dyssynchrony.
So that's an important question, but we have to recognize that we didn't do the work perfectly yet because we don't have enough data in the literature to push forward and to say, yes, do echo and assess dysynchrony to select patient for CAT. We cannot say that up to now. We really have to be careful, and we can use imaging techniques to look for dysynchrony, but we cannot send a patient to CRT according to the imaging techniques. We have to follow the ESC guidelines. But if we want to use echo techniques, imaging techniques, we know that the septal flash, it is quite easy to get, is something that is feasible, quite important because you can best select patients if you use septal flash. You can also use the apical rocking, so the strange motion of the apex in apical four-chamber view that is also associated with the success rate of CRT. But these are qualitative tools. So if you want to quantify things, probably the pressure strain loops will provide new parameters that will be very important. But up to now, I think that using the GLS and the regional assessment of the curves might be very important.
Okay, thank you very much. I think we should move, but perhaps before moving, we can just take very brief answer to a question which is somehow related to LV function, is a question about peak atrial strain and whether this is useful in assessing left ventricular diastolic dysfunction.
That's a good question.
It's a nice one, so I know you like it, so that's why I'm asking you.
Yes, actually you would like this aspect too. So LS strain is still a matter of research. It's not for the daily clinical practice, but that's true that if we use the speckle tracking software to check for the LA function, we can easily have an access to the reservoir function. And this reservoir function seems to be correlated with the risk of arrhythmias, atrial arrhythmias, with the risk of stroke, and it might be also a tool that could be used for diastolic function assessment. But I think it's really too early to consider this tool for the diastolic function assessment. The assessment of diastolic function is quite complicated. We have a new algorithm. There is a lot of discussion about the use of this algorithm. So I think we have to use simple tools. We have to be physician first, to start by a clinical assessment of our patient, and then we use echo to confirm what we feel with the clinical assessment. But echo for its own is not good. It's not good.
Perhaps research-wise, it's interesting to look into, and for the future, we know it relates to filling pressures, left atrial strain, but it's still a long way into routine clinical practice. So please let us move to the last section.
Okay, so thank you. So we will discuss in few posters that have been presented in Lisbon, cardiomyopathies and heart failure. And first of all, we come back to the mechanical dispersion, and you will see that this paper presented by our colleague from Oslo, it's quite interesting. This is a study performed in more than 100 arrhythmogenic cardiomyopathies patients, and all these patients, when they were included in the study, were real arrhythmogenic cardiomyopathy patients, but without previous life-threatening ventricular arrhythmia. And all these patients were perfectly assessed by echo and were followed for up to 4 years. And you will see that it is quite interesting to see that you can distinguish 3 groups of patients based on 2 parameters that can distinguish patients at risk for ventricular arrhythmias and patients who are not at risk for ventricular arrhythmias. And these 2 parameters are the mechanical dispersion that you can measure in the LV, in the left ventricle, and the second parameter is the right ventricular strain. And you see that with these 2 cutoffs of 45 milliseconds for the LV mechanical dispersion, and with this cutoff of minus 23% for the RV longitudinal strain, we can distinguish 3 groups of patients: the ones who will not have any ventricular arrhythmias, who have no dispersion and a preserved RV function; the one who will have a high risk of ventricular arrhythmias, who have a mechanical dispersion in the LV and a decrease in RV function, and the group between the two previous ones. So this is quite interesting to consider this mechanical dispersion and this trend analysis. And now I can discuss this beautiful study that has been performed in Leuven in Jan-Suve Voigt group. And this is a big study performed in more than 300 consecutive heart transplant grafts recipients. And all these patients were perfectly followed for a long period of time with very good echo images. And the goal of the study was to know if, considering the strain assessment of these patients, we can predict the risk of cellular graft rejection or the risk of humoral graft rejection using echo data. And you can see, and it's quite impressive, that if you consider the risk of humoral graft rejection, you can predict very early this risk in the patient who will have this rejection, considering the global longitudinal strain. You cannot predict anything with the ejection fraction. You can hardly predict this humoral graft rejection with a circumferential strain, but you can nicely predict this risk considering the GLS in these heart transplant patients. So please consider this study because it's a very interesting one to predict the risk of rejection, humoral graft rejection in patients who have been treated by heart transplants. And before that I end my talk, I want just to discuss a bit about myocardial infarction. Myocardial infarction, and again, I come back to the initial posters that I presented about cardiac magnetic resonance imaging and the use of facial tracking to get an assessment of myocardial function. This is a huge study that has been performed in Germany, and the authors were able to measure the GLS, the radial strain, the circumferential strain using the cardiac magnetic resonance imaging. And they did that in more than 1,000 patients admitted for an acute myocardial infarction. And they followed this patient looking for MESs. And you will see that they were able to measure a lot of parameters, the size of the infarction, the LV ejection fraction, the volumes, the area at risk, and they were able to measure the strain parameters. And you will see that you can easily distinguish groups of patients according to the risk of MESs using the strain data. And in that study, the authors were able to demonstrate that GLS is the only cardiac MR facial tracking index independently associated with the risk of MES. And of course, as we come back to what we were discussing before, you see that this parameter is an independent prognostic marker, but in the clinical practice, of course, we will have to measure the LV ejection fraction. But using, in addition to LV ejection fraction, the GLS, we improve the way we assess the risk of event in our patients. And you see that in red, the patient with a decrease in LV ejection fraction and a decrease in GLS have a much higher risk of event than the patient who have a preserved LV ejection fraction and a decrease in GLS. So it's very important to use GLS in echo, in CMR, in addition to the assessment of LV ejection fraction. So before that I end my talk, I want to thank all the colleagues who were fundamental to be able to do this presentation today. These colleagues are friends, and they were able to present their work at the highlight session on Saturday in Lisbon a few weeks ago. I want to highlight Denisa Moraro, who did an important work on new technologies, Jordi Dahl about valvular heart disease, Owen Miller, who always do an extremely brilliant work about congenital heart disease, Alessia Gimelli, who did all the work for nuclear imaging on cardiac CT, Kaia Buccilli-Ducci, who did the work for the cardiac magnetic resonance imaging, and Christina Oga, who did all the work perfectly for heart failure. Thank you very much.
Thank you. Thank you very much, Ervan. Again, it was a great part. Of course, in such a 1-hour webinar, we cannot cover everything. We received different questions, so we just selected on around 3 large topics, the ones that we thought are the best original abstracts presented, and we are trying to cover also other issues beyond these abstracts. So I think, again, the field of arrhythmogenic cardiomyopathy is a very hot one, and we get more understanding of it with the new technologies. And now it has shifted from a right ventricular disease, it used to be called arrhythmogenic right ventricular cardiomyopathy, to a more global disease, as we saw that the left ventricle is also involved. And the latest version of the EACVI recommendation on this disease names it as such, arrhythmogenic cardiomyopathy. So it was interesting to see that by combining information about right ventricular function using strain and left ventricular function using mechanical dispersion, one can get incremental information. And that's an important point to remember, and we will for sure hear more about that. The other things relate again to LV function, this time by CMR tracking. And I think we've discussed it quite at large. And so maybe it's time to again take some questions. We have received many questions in the meantime. So one which was related to the second section but is relevant here what are the main differences between a hypertrophic cardiomyopathy patient and an athletic heart in terms of imaging? What would you think that are the main features helping us to differentiate? We just mentioned.
Yeah. So I think it's easy to keep simple messages. First, if you are an athlete, you should have an enlargement of the LV and also of the LA most of the time. So an athlete shouldn't have a small left ventricle. If you have a small left ventricle, it probably means that this is a sick heart. So the size of the LV should be increased in an athlete. If we consider the strain data, we saw that the dispersion seems to be very powerful to distinguish athletes from hypertrophic cardiomyopathy, or I should say athletes from abnormal LV. So dispersion could be considered. And also, we can use exercise stress echo, and it's a way maybe to promote the next EuroEcho-Imaging Congress, because during the next EuroEcho-Imaging Congress in Milan, one of the main themes will be exercise and sport, because we know now that we can use our imaging technique at rest, but most of our patients are symptomatic during an exercise, when they exercise, and then we can use our techniques at rest and during an exercise to best assess the function, the systolic, the diastolic function, and the consequences of the change in load when we exercise. So in athletes, to distinguish normal heart with abnormal heart, considering an exercise stress echo or considering an exercise cardiac MR could be something to consider.
Yeah, indeed. Again, I think stress echo is the main player here. You have better longitudinal function for sure. And then with stress, this can even improve, while in a hypertrophic cardiomyopathy patient, it will deteriorate most often. And there are a number of things that we can do. One other question relates again to stress echo, whether this can be used in symptomatic patients with heart failure, and if so, which modality and what precautions would you take?
So stress echo in heart failure, that's complicated. Maybe we can use stress echo to assess the presence of variability.
Right. So again, probably dobutamine one can use.
So dobutamine is a small dosage of dobutamine. Exercise is more complicated. We can use exercise stress echo in heart failure patient to check for symptoms. If we have a patient who seems to be stabilized by the medical treatment, but still highly symptomatic, we can do an exercise stress echo to see if we have a very rapid increase in pulmonary pressures, if we have a severe mitral regurg related to the severity of the LV dysfunction. So it might be a way to best understand the symptoms of the patient. But I don't think that we can nowadays decide to treat the secondary mitral regurg based only on the exercise stress echo. So
yes,
stress echo is perhaps something to best understand what the patient is telling us, or something that can be used to test for the presence of variability. This is true for the chemotherapy-induced cardiomyopathies. This is true also before cardiac resynchronization therapy, but it's not used in most of the labs, I think. It's mainly for specific patients when we are in doubt for the indication for the treatment.
Right. I think it's still very much underused in general, but then, of course, in specific clinical scenario, you need to think of it. Dear colleagues, time is flying, so we are getting close to the end. So I just want to take the last minute to wrap up this interesting webinar. First of all, by thanking Ervan for his hard work on putting together this interesting information. Again, to the Scientific Program Committee and to those that were listed and named by Ervan as they were speakers in the highlight session, and the EACVI Board as a whole. For you, again, Don't forget to renew your membership or to become an EACVI member, because there's lots of benefits you can get by being a member, not least education products, and you can attend congresses such as this great one that we discussed, or courses during the year. No later than in 2 weeks we will have a large CMR Congress in Barcelona, and we are inviting you there. You can sit an exam and prove your value and get recognition for your work. And finally, last but not least, don't forget to participate in December EuroEcho 2018 in Milan between 5 and 8 of December. 2 very relevant themes: valvular heart disease, exercise and sport. And so we wait for you there. And in the meantime, please stay tuned, stay close to the EACVI, and let us know how we can help you. Thank you very much for attending this webinar, and have a good evening.